All right, let's dive right into this explainer where we are going to cut through the notoriously dense pharmacology of antipsychotics like a sharp knife through warm butter. Seriously, if you've ever looked at a textbook on this topic and immediately wanted to take a nap, you are absolutely in the right place. We're going to break this all down step by step so it actually makes perfect sense.
You know, to borrow a little dramatic flair from Charles Dickens, and honestly, as anyone who has ever cracked open a certain classic massive pharmacology textbook knows, studying this stuff can truly feel like the winter of despair. Learning this is hard, but we're going to use a little whiteboard magic today to make sure these complex concepts stick in your brain permanently. No more staring blankly at giant lists of drug names, okay? We're building your understanding from the ground up.
To keep things simple and lower your cognitive load, here is our roadmap. We'll start with a quick intro to schizophrenia itself, then classify our pharmacological tools, look at exactly how they work, navigate the big side effects, and finally, wrap up with the actual clinical treatment strategy.
So, starting right at the beginning with the underlying problem, before we can treat schizophrenia, which is a chronic psychosis affecting about 1% of the population, we really have to understand what it looks like clinically. Here is a great rule for learning. Say what you write what you say. So picture drawing a massive plus sign on one side of your mental whiteboard and a big minus sign on the other. Schizophrenia divides cleanly into positive symptoms that add things to reality, like hallucinations, delusions, and disturbed thoughts, and negative symptoms that subtract from normal human function, things like a blunted affect, apathy, and impaired attention. Right, so what is actually misfiring inside the brain to cause this? The crucial point to remember is that it's a profound biochemical abnormality in the dopaminergic pathways. Think of it as a severe dopamine imbalance. Having way too much dopamine activity in the mesolimbic pathway, that gives you those positive symptoms. But a dysregulation in the mesocortical pathway, that's what contributes to the negative ones. It's all about that imbalance.
Okay, so dopamine is the main culprit here. How do we fix it? That brings us to our pharmacological tools, specifically the two major generations of antipsychotic medications. We basically categorize these tools into older, first-generation typical agents and newer, second-generation atypical agents. The first-generation drugs are further split based on their receptor affinity, so you've got high-potency options like haloperidol and low-potency ones like chlorpromazine. Then we have our second-generation atypicals. And hey, here's a quick mnemonic to help you remember these. Quiet, please, only whispers and respite, which gives you quetiapine, olanzapine, and risperidone. Super handy, right?
Now we know what the drugs are, but let's look at exactly how these molecules work. How do they block signals in the central nervous system to bring all that dopamine chaos back under control?
Just imagine the drug as a key and the receptor as a lock. First-generation typical drugs act kind of like a brute force key. They primarily bind really tightly to D2 dopamine receptors in the brain and block them. But the second-generation atypicals, they are a lot more nuanced and actually cast a much wider net. When we say a drug has an atypical mechanism, it means it owes its unique activity to a dual blockade. They block both serotonin, specifically the 5-HT2A receptors, and dopamine D2 receptors. And why does this matter? Well, because while first-generation drugs are great at fighting the positive symptoms, this dual action of the atypicals actually helps improve those really tricky negative symptoms too. It's essentially a pharmacological two-for-one deal.
Time to snap back to attention for a quick pop quiz. And speaking of the old joke from the Confused Neuron channel, why did the confused neuron misfire? Because it forgot its receptors. Corny, I know, but please don't make a simple mistake on your exam. If you are asked what receptors atypicals block, remember, they block both D2 and 5-HT2A receptors. That serotonin blockade is literally the secret sauce.
As we always say in pharmacology, there are absolutely no perfect solutions in life, only trade-offs. Every single medication has side effects, so let's navigate the rather rugged landscape of the complications associated with these drugs. When you block dopamine in the brain's nigrostriatal pathway, you get extrapyramidal symptoms, or EPS, and they follow a very distinct timeline. Just remember the mnemonic ADAPT to map this out. Acute dystonia happens in hours, akathisia in days, Parkinsonism shows up in weeks, and tardive dyskinesia develops over months to years.
And this right here is the ultimate trade-off. You want to avoid those terrible extrapyramidal motor risks? Great, you use a second-generation atypical drug. They have a much lower EPS risk. But here is the catch. By doing that, you significantly increase the metabolic risks. We're talking major weight gain, hyperlipidemia, and exacerbating diabetes. You are quite literally trading a motor problem for a metabolic problem.
Aside from the everyday side effects, there are a few fatal complications you absolutely must memorize. Neuroleptic malignant syndrome is a massive medical emergency. Remember the symptoms with the word fever. Fever, encephalopathy, vitals unstable, elevated enzymes, and rigidity. If you see this, stop the drug immediately. Also, watch out for Clozapine causing agranulocytosis, which means it suppresses the bone marrow and just wrecks white blood cells. Thioridazine can cause dangerous QT prolongation in the heart. And of course, keep an eye out for general antimuscarinic effects like dry mouth and urinary retention.
Okay, we've covered the disease, the drugs, and the risks. Let's synthesize all of this dense pharmacology into a crystal-clear clinical strategy for our patients.
Your treatment algorithm is actually pretty straightforward. Step 1, start with atypical second-generation agents as your first-line therapy. This protects the patient's motor function from those brutal EPS side effects right out of the gate. Step 2, tailor the exact drug to the patient. If they already have diabetes, you'll definitely want to avoid atypicals known for massive weight gain, like Olanzapine. Step 3, hold your heavy hitter Clozapine in reserve. You only use it for refractory, treatment-resistant patients, and you have to strictly monitor their white blood cell counts.
So, you now have the tools to fully grasp this delicate clinical balancing act. You know that managing schizophrenia isn't just about broadly shutting down dopamine. It's about navigating a really complex maze of serotonin receptors, motor risks, and metabolic realities. So how will you balance providing your patient true relief from psychosis while keeping them safe from that metabolic winter of despair? Keep that question in the back of your mind because you are now perfectly prepped to conquer your next pharmacological